Recording in progress.
Use of perioperative chemotherapy in colorectal cancer metastatic to the liver. Abstract. The curative intent approach may improve survival in carefully selected patients with oligometastatic colorectal cancer. Aggressive treatments are most frequently administered to patients with isolated liver metastasis, though there may be judiciously considered for other sites of metastasis. To be considered for curative intent with surgery, patients must have disease that can be definitely treated while leaving a sufficient functional liver remnant. Neoadjuvant chemotherapy may be used for upfront resectable disease as a test of tumor biology and/or for upfront unresectable disease to increase the likelihood of resectability, so-called conversion chemotherapy. While conversion chemotherapy in this setting aims to improve survival, the choice of a regimen remains a complex and highly individualized decision. In this review, we discuss the role of RAS status, primary sidedness, and other clinical features that affect chemotherapy treatment selection, as well as key factors of patients that guide individualized patient treatment recommendations for colorectal cancer patients being considered for definitive treatment with metastasectomy. Keywords: metastatic colorectal cancer, perioperative chemotherapy, conversion chemotherapy, liver resection, KRS, steatohepatitis. Introduction. While historically the mainstay of metastatic colorectal cancer therapy has been palliative chemotherapy, now in selected patients with metastasis, resection can offer a possibility of cure. Compared to 5-year overall survival, OS rate of 13.8%, survival outcomes may be much better in patients undergoing a more aggressive treatment approach. Resection of liver metastasis is by far the most common and most well-studied, but must be considered on a case-by-case basis. Unfortunately, only 10 to 20% of patients presenting with isolated hepatic metastasis have resectable disease. The remaining 80% are typically considered unresectable either due to extrahepatic disease, involvement of too large a liver volume, or locations involving crucial structures. There is now There is now substantial evidence to support the use of neoadjuvant chemotherapy in selected patients to downsize tumors and therefore facilitate a curative approach with resection. With the use of neoadjuvant chemotherapy, early studies showed that the proportion of patients eligible for resection could increase by over 10%, which has further improved with more modern regimens. Acknowledging the highly selective nature of these retrospective studies, resection in this population has continually been shown to improve survival. Numerous studies show 5-year OS rates ranging from 25% to 58%, similar to those who presented with initially resectable liver metastasis. One study demonstrated a 10-year OS rate of 27%, which is a substantial improvement over the current 5-year OS rate of 13.8 expected with chemotherapy alone. Here we discuss patients with metastatic colorectal cancer are most likely to benefit from an aggressive approach to definitely address all sites of disease in the so-called curative intent approach and review the use of perioperative chemotherapy to achieve the maximum benefit from this strategy. Patient selection. Optimally selecting who may benefit from an aggressive curative intent approach. Patient selection is crucial when deciding which patients with metastatic disease would benefit from curative intent treatment. The survival benefit is restricted to patients in whom all sites can be reasonably definitely treated. This requires early and frequent multidisciplinary review to decide which patients are appropriate candidates. As the goal of curative intent is to remove all viable disease, the decision to aggressively treat metastatic disease is largely driven by factors influencing resectability. While there are no set criteria to determine resectability, factors associated with improved outcomes include the number of metastases, the sites of metastatic disease, favoring a unilateral and/or unifocal disease, limited primary tumor stage, and long disease-free interval if metastases are metachronous. Metachronous. The best outcomes have historically been seen in patients with no major pre-existing medical comorbidities, fewer than 3 metastases, no extrahepatic disease, and predicted clear surgical margins. Metastasis site considerations. Curative intent therapy is most often pursued and has been best studied in patients with liver metastasis. For patients with isolated liver metastasis, possible management strategies for liver-directed therapy include surgery, ablation, yttrium-90, Y90, yttrium-90, Y90, radioembolization, chemoembolization, and external beam radiation. However, hepatic resection remains the only proven cure for liver metastasis. Decisions regarding isolated extrahepatic disease are more complicated, with the best 5-year OS seen in patients with isolated lung metastasis or periportal lymphadenopathy. In patients with a few isolated or long-term stable lung metastasis, it may still be reasonable to pursue curative intent treatment. A localized therapy technique, surgery, ablation, irradiation. Patients with limited volume peritoneal disease have intermediate 5-year survival, and aggressive treatment strategies remain very controversial. In highly selected patients, cytoreduction and intraperitoneal chemotherapy are occasionally considered, but the benefit remains unproven. Patients with aortocaval adenopathy or multiple sites of disease have the worst survival, and data do not exist to support aggressive treatment strategies in this population. Needless to say, it is imperative that patients receive appropriate high-quality imaging, typically a contrasted computed tomography scan of the chest, abdomen, and pelvis to accurately assess the extent of their metastatic disease. Resectability. For patients to be considered for treatment with curative intent, all viable disease must be either resectable or have the possibility to convert to resectable disease with downstaging by chemotherapy. Though various definitions of resectability exist, key factors include the estimated volume of functional liver, remnants that will remain following resection, and whether there is involvement of non-resectable structures such as major vessels. Following resection, there should be a predicted sufficient Following resection, there should be a predicted sufficient remaining liver remnant volume, typically more than 30%, adequate perfusion, and biliary drainage, and adequate function. There is also often a subjective component, including surgeon opinions, about technical appearability and attitudes about the risk of resection. While an R0 resection, negative margins, is ideal, given increasing surgical indications, R1 resections with microscopically positive margins, may be justified for certain patients, but do not connote a higher local recurrence risk. Conclusions. Patients may be appropriate for treatment with curative intent if all sites of disease can be reasonably definitely treated. Appropriate patient selection is crucial and should involve multidisciplinary review. Curative intent treatment is most often recommended for patients with isolated liver metastasis, though it may be reasonable to consider this more aggressive strategy for highly selected patients with lung metastasis or periportal adenopathy. Localized treatment of peritoneal disease remains controversial. Resectability should include an assessment of predicted remaining liver volume, liver function, and disease involvement of crucial structures, such as major blood vessels. Choice of neoadjuvant treatment. The goal of neoadjuvant chemotherapy is metastatic colorectal cancer. In metastatic colorectal cancer is ultimately to improve OS by improving complete surgical resection. But the role of chemotherapy is different depending on whether the disease is resectable or not at diagnosis. For upfront resectable metastasis, chemotherapy primarily acts as a test of tumor biology, helping to identify aggressive cancers that are likely to recur quickly after surgery. Studies have shown that the pathologic response to preoperative chemotherapy is strongly predictive of prognosis after a resection. Additionally, development of any lesions during chemotherapy is one of the strongest predictors of poor post-hepatectomy outcomes. The response rate can be assessed by standardized methods such as the response evaluation criteria in solid tumors, RECIST. This method has proved to be a reasonable method for evaluating chemotherapy response. However, In addition to tumor size, there are other important considerations, including morphologic changes and metabolic activity. Morphologic features are increasingly important, and studies suggest that tumor size alone is an imperfect predictor of pathologic response and survival, particularly for biological agents such as BVS, just a second, as bevacizumab. For initially unresectable disease, chemotherapy also provides information about tumor biology, but it is done primarily to increase the likelihood and/or allow R0 resection of metastasis and presumably improve OS. Volprecht et al. Demonstrated that there was a strong correlation between response rates and resection rates in studies of patients with isolated liver metastasis. R equals 0.96, P equals 0.002. It is therefore critical to select a regimen with high response rates for patients with metastasis that could become resectable. While high response rates are desirable, the goal is not to achieve a maximum or complete response, as over-treating increases toxicity and can make the surgery technically difficult, in turn causing loss of the window of resectability. While many treatment combinations have been studied for neoadjuvant treatment in metastatic colorectal cancer, there is currently no standard of care and guidelines to allow several combinations. Upfront resectable metastatic disease. Perioperative chemotherapy for resectable disease is frequently done in clinical practice to evaluate tumor biology, but has limited randomized data. The landmark EORTG 40983 trial by Nodlinger et al. Examined the use of perioperative Folfox, folinic acid, fluorouracil, and oxaliplatin before and after surgery versus surgery alone in patients with upfront resectable liver metastasis from colorectal cancer. In this trial, resectability was judged by a multidisciplinary team. They demonstrated a statistically significant improvement in progression-free survival, PFS, 20.9 months versus 12.5 months, P equals 0.035 in the chemotherapy group. However, there was no difference in OS with the addition of perioperative chemotherapy versus surgery alone, 61.3 months versus 54.3 months, p equals 0.34, making the application of this approach controversial. Even more limited data are available for the use of targeted therapies, including cetuximab in the perioperative setting for upfront resectable liver metastasis in colorectal cancer. The new EPOG trial examined perioperative chemotherapy either with or without cetuximab for resectable liver-only metastasis. Liver-only metastasis. Surprisingly, they observed a detrimental effect in patients who received FOLFOX with cetuximab compared with those receiving FOLFOX alone. PFS 14.1 months versus 20.5 months, hazard ratio HR 1.48, p equals 0.03. This detrimental effect was more pronounced in patients with a better prognosis and those who responded to treatment. Possible explanations for this finding include differences in baseline characteristics, differences in definitive management. The FOLFOX alone arm had more resections, while the FOLFOX with cetuximab arm had more ablations and fewer resections, and more positive margins in the cetuximab arm. Interestingly, this outcome was not thought to be due to overlapping toxicities which have been previously described. Additionally, outcome data were missing in 11% of patients, which may have skewed their conclusions. Regardless, these data argue against the utility of chemotherapy with anti-AGFR, epidermal growth factor receptor, therapy in patients with upfront resectable liver metastasis. Randomized data for chemotherapy with bevacizumab is in upfront resectable disease are lacking. Safety and toxicity. The balance between efficacy and toxicity remains of paramount importance. Toxicity associated with perioperative chemotherapy may additionally impact surgical outcomes. Oxaliplatin has been associated with an increased sinusoidal injury, but doesn't increase perioperative morbidity or mortality. However, irinotecan has been associated with an increased risk of steatohepatitis. of risk of steatohepatitis, which is associated with increased post-operative mortality due to death from liver failure, 14.7% versus 1.6%, p equals 0.001. Bevacizumab may cause issues with post-operative bleeding and wound healing, so it should ideally be discontinued 4 to 6 weeks prior to surgery to reduce the risk of post-operative complications. Carroy et al. Also observed an effect based on chemotherapy duration. Notably, they found that prolonged preoperative chemotherapy increased the risks of post-operative complications. Complication rate 54% for patients undergoing more than 6 cycles of neoadjuvant chemotherapy versus 19% for those receiving fewer than 6 cycles, p equals 0.047, primarily due to transient post-operative liver insufficiency. However, even with prolonged chemotherapy, there was no major impact on mortality in the setting of hepatic resection. Therefore, the duration, timing, the type of chemotherapy should be carefully considered to minimize toxicity and post-operative complications. This also reinforces the goal of using neoadjuvant chemotherapy with the aim of converting to resectable disease, not treating to maximum chemotherapy effect. Upfront unresectable metastatic disease. Perioperative chemotherapy for patients with initially unresectable liver metastasis has been well studied. Upfront aggressive systemic chemotherapy in this setting can allow a patient with unresectable disease to be converted to resectable and is therefore referred to as conversion therapy. Conversion chemotherapy has shown a clear survival benefit, with 5-year OS rates ranging from 25% to 58% versus 5% to 10% with chemotherapy alone. Most initial studies of conversion chemotherapy were performed using oxaliplatin. And fluorouracil-based regimens, Volfox and FOLFIRI, fluorouracil, folinic acid, and irinotecan are both commonly used doublet regimens that have been widely accepted as conversion treatment strategies based on their utility in stage 4 colorectal cancer in general. In a randomized trial comparing FOLFIRI and FOLFOX, the two regimens had identical response rates, 55%, and similar levels of R0 resections. In two prospective phase 2 trials, FOLFOX and FOLFIRI also showed similar response rates of approximately 50%, with similar rates of liver metastasis resection, 33% and 40% respectively. While both have demonstrated similar efficacy, it is reasonable to choose an oxaliplatin-based regimen due to the perioperative toxicity concerns discussed above. Triplet regimens including FOLFOXIRI, FOLFIRINOX, folinic acid, fluorouracil, oxaliplatin, and irinotecan have also been studied. Falcone et al. Showed that compared to FOLFIRI, FOLFOXIRI improves response rates, PFS, OS, and increases resection rates, 15% in the FOLFOXIRI arm versus 6% FOLFIRI arm, P equals 0.033, for patients with metastatic colorectal cancer. In the study's multivariate analysis, only FOLFOXIRI treatment was an independent predictive factor for achieving an R0 resection. HR 3.1, 95% confidence interval, GI 1.2 to 7.9, P equals 0.018. However, there was increased toxicity with FOLFOXIRI. The METHAP trial by Ito et al. Studied doublet regimens, FOLFOX or FOLFIRI versus intensified chemotherapy, high-dose FOLFIRI, FOLFOX7, FOLFIRINOX, in patients with potentially resectable or unresectable liver-only metastasis. They also found that FOLFIRINOX had high response rates and resulted in secondary resection in 52% of patients overall, but only 40% of patients received a chemotherapy doublet versus a chemotherapy doublet versus 67% of patients who received the FOLFIRINOX chemotherapy triplet. Use of targeted therapies. Anti-EGFR targeted treatments. Anti-EGFR targeted therapies including cetuximab and panitumumab including cetuximab and panitumumab have been studied as potential adjuncts for conversion chemotherapy for colorectal cancer with liver metastasis.